Today, we're going to talk about holding cardiovascular medications prior to surgery. Now, as you all know, getting patients ready for surgery and giving them adequate instructions so they may get through the surgery safely is very important. One of the biggest challenges we face in perioperative medicine is deciding which medicines to hold before and or after surgery and when to reinitiate them. My name is Sunil Sahai. I'm professor and division chief of general medicine at UTMB in Galveston. So our paper is Perioperative Management of Cardiovascular Medications, a Society of Perioperative Assessment and Quality Improvement consensus statement coming out in the September issue of Mayo Clinic Proceedings. For the last 2.5 years, a select group of Society of Perioperative Assessment and Quality Improvement members have been working on a consensus statement to go over numerous classes of cardiovascular drugs and come up with findings and expert recommendations on which medications to hold right before surgery. The main thing I want you all to remember is that we have to individualize care for every patient, and our recommendations are consensus statements based on the literature and our personal experience of the 13 members involved in the writing group. The writing group consists of internal medicine physicians and anesthesiologists who are all involved in perioperative medicine. And the Society of Perioperative Medicine and Quality Improvement is an international organization that is dedicated to providing the best, up-to-date, and most evidence-based recommendations for care of the perioperative patient. We went through multiple iterations of the Delphi process to come to our final conclusions. In the 2.5 years, the practice of medicine has changed in regard to certain medications, and we actually had to go back and do a repeat Delphi process for the SGLT2 inhibitors, because those are now recommended for management of heart failure patients. What you have in front of you is the end result of that process. We looked at over 20 plus classes of drugs, including medications such as renin inhibitors, antiarrhythmics, sodium channel blockers, beta blockers, diuretics, and others. These recommendations were made on the best available evidence in the medical literature, and also based on personal experience of the writing group. We feel that they are recommendations that can be used in virtually any setting in the perioperative realm, especially in pre-op clinics. We also recommend that patient care be individualized for certain medications. For example, not all blood pressure medicines, including ACE and ARBs, need to be held prior to surgery if the procedure is of a relatively low risk, such as cataract surgery. All too often, situations occur where we tell patients to hold medications before surgery because of the risk of issues in the perioperative period. However, in the case of medications such as ACE inhibitors or ARBs, holding the medication may have the patient show up on the morning of surgery as being hypertensive, and therefore the case gets canceled. For low-risk procedures, we actually do recommend an individualized approach. For a patient who has tenuous blood pressure control prior to surgery, it may make more sense to continue the ACE or ARB in the perioperative period versus holding it. Additionally, for example, with diuretics, we need to be very careful as to why the patient is on them. If the patient is on certain diuretics for heart failure, holding diuretics in the morning of surgery may not be the best recommendation, as that patient may show up with fluid overload and as such cause issues during the perioperative period. We all recommend an individualized approach to the patient and also giving consistent instructions to every patient as to how to take care of their medications. For example, with the SGLT2 inhibitors, these are increasingly being prescribed for patients for heart failure and not necessarily diabetes. We do know that there is an increased risk of euglycemic DKA in the postoperative period for some of these patients. Therefore, we recommend holding these medications prior to surgery. And be conscious of the fact that the patient may be on these medications without a diagnosis of diabetes. If you are a patient watching this, please ask your surgeon, physician, or anesthesiologist several days before surgery about which medications you should take on the morning of surgery or which ones you should hold. We feel it's very important that holding medications prior to surgery does not cause further harm downstream after the procedure. So I highly encourage you to bring a complete medication list to your appointment with your physician or surgeon and the anesthesiology team, and go over every medicine you have and determine when you should take them prior to surgery. By working together with your treatment team, you can minimize the risk of complications and also make the surgery a success. We hope to revisit these guidelines in approximately 5 years to give updated recommendations based on more literature review. I would like to thank the team of authors that worked with me for 2.5 years through pandemics, hurricanes, freezes, and blizzards to get this project up and off to the presses. I would also thank the Mayo Clinic staff for working with us over these last 2.5 years and the Society of Perioperative Assessment Quality Improvement of making this a reality.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.